All right, so looking at drugs for treating diabetes and disordered glucose metabolism. So in this talk, we're going to be looking at, again, to kind of complement and much of what we're going to talk about is obviously, again, going to parallel what we discussed in pathology, particularly as a result as it relates back to diabetes. So the endocrine system chapter did look at some other endocrine conditions, and again, some of the hormones and things like that. For instance, we discussed some of the things like, for instance, with birth control in the renal and urogenital drugs. So this focus here is going to really be on diabetes. Again, we're going to be reviewing some of the pathology. So some of the notes will kind of parallel what we looked at in the pathology discussion in that chapter in the clinical pathology book. But really what we're going to look at even more so now is, again, being able to recognize the specific treatments as it relates to type 1 and type 2 diabetes. So again, to review glucose metabolism, and again, obviously complement this with what you learned in the pathology section. So again, when we look at our blood sugar, it's basically looking at the amount of glucose that's kind of going around between the liver and the circulation, and we kind of have our optimal levels. Those levels change based upon whether we eat, what we have to eat. So again, insulin is really the only hormone that's going to lower blood glucose. Insulin also decreases lipolysis, which is the use of fats as a fuel source. So again, look at insulin and kind of how that interacts. Don't forget about the other hormones as they relate to glucose metabolism. So obviously there's other hormones as it relates to glucose metabolism. You have glucagon, epinephrine, growth hormone, glucocorticoids. So what they do as far as like glucose metabolism, so make sure that you're familiar with that and make note of that. Okay, so again, the pancreas is going to be responsible for controlling blood glucose as well as it relates to that release of insulin. So serum insulin levels are going to rise after meals, and part of the reason for that is because of, again, so as you take in your meal, your blood glucose is going to be effectively your glucose levels are going to rise. So the idea is, in order to maintain homeostasis, the pancreas is going to release insulin. Insulin kind of uptakes that glucose in order to kind of manage the blood sugar. So essentially, insulin basically acts on glucose in three different ways. So as it's going to increase glucose transport into the skeletal muscle and adipose tissue. So that's one thing that glucose will do. It also increases glycogen synthesis and decreases gluconeogenesis. So those things are going to be what basically insulin secretion on glucose is effectively going to accomplish. So categories of glucose homeostasis. So normal fasting blood glucose, 60 to 100 milligrams per deciliter. So when you're fasting, you go to get blood work done, your blood glucose should be somewhere between 60 and 100. Euglycemia is postprandial, or after you consume a meal. So, however, you should be below 140 milligrams per deciliters within 2 hours of a meal. Okay, so that's going to be what you're looking at as far as euglycemia. Hypoglycemia, and that's going to be one of the issues that we deal with individuals with diabetes, particularly with type 1, who are taking insulin. So, and again, there you're looking at less than 70 milligrams per deciliter. Hyperglycemia, so pre-diabetes, and then levels where individuals get diagnosed with diabetes. So again, individuals are considered pre-diabetic, or they have impaired fasting blood glucose when it falls between 100 and 125. And usually what you look at is, another thing you look at with pre-diabetes is just the impaired glucose tolerance, which is where glucose levels will fall between 140 and 199 2 hours after ingesting what they call a 75-gram liquid glucose solution. So basically they could test someone's glucose tolerance by having them ingest a glucose solution, and if their levels go between 140 and 199 after the ingestion of that within 2 hours, then they're deemed to have impaired glucose tolerance. Diabetes is going to get diagnosed with levels greater than 100, if you're with levels above 126. So that's what you look at as far as like your categories of glucose homeostasis and kind of how individuals will get diagnosed with diabetes. So when we're looking at our metabolic disorders discussed here, so hyperglycemia, so you're going to see this in individuals with type 1 and type 2 diabetes. So that's basically how diabetes is going to get diagnosed, is by having elevated levels of blood glucose. And again, what we're concerned about here is if blood sugar levels aren't stabilized, the damage that you could have to other areas of the body. So retinopathy is very common in poorly controlled diabetics, neuropathies, nephropathy. So the kidneys can get stressed with this. You know, the nerves in your eye, or just nerves in general, you can have issues as it relates to this. And then another thing we have to be concerned about is hypoglycemia. So hypoglycemia is going to be a common problem in individuals who are going to use exogenous insulin in order to manage their blood glucose. So again, typically that's going to be in type 1. However, some type 2 diabetics do end up using insulin in addition to their anti-diabetic medications in order to manage it. And typically what you see from a pathological standpoint, like in individuals, type 1 diabetics will normally have trouble with hypoglycemia. Obviously, their blood sugar levels can go up as well if they don't take their insulin the way they're supposed to. Whereas type 2 diabetics, they usually have issues with hyperglycemia. Another really important thing that kind of gets looked at in the diagnosis, and you want to be sure that you're aware of, is the relationship of what we call HbA1c. So HbA1c basically is measuring the exposure of proteins in the blood, particularly hemoglobin, to elevated glucose levels. So what eventually ends up happening is, if blood glucose levels are elevated, prolonged, you get this what they call glycation of these proteins. So what this basically means is to make it really sound kind of simple, it's basically the glucose in the blood almost like attaches itself to the proteins, and the HbA1c measures that. So that's something that will also not only help in diagnosis, but it also helps and you should know what normal HbA1c levels are. It also helps in being able to look at how well the treatment plans are working for people who have diabetes. So that'll be something that'll also be monitored as something that can help in seeing how well controlled somebody has their diabetes. So really handy kind of chart from your book. This kind of, again, and we covered this in the pathology section, but again, as a quick review here, you see the difference between type 1 and type 2 diabetes. So, some important things to look at: age of onset, associated obesity, the propensity to ketoacidosis requiring insulin for treatment for control, plasma levels of endogenous insulin. So, again, the primary thing, if we were to sum this up as far as the differences that we look at here, is that in individuals who have type 1 diabetes, essentially their body, just as we talked about, the pancreas stops producing insulin, okay? In type 2 diabetics, they still produce insulin. Now, if you notice here, we talk about how it's variable. Their insulin levels may go low, they may be normal, they may be elevated. It depends on the degree of insulin resistance and the insulin secretory defect. In other words, it's going to vary a bit more with type 2, but pretty much for the most part, type 2 diabetics are still producing insulin. In some cases, their insulin levels may actually be very high. It's essentially the body forgets how to use it, okay? So we look at, again, some of the other things here. Again, the different health issues that respond to that. And again, usually you see some of the differences. One of the other differences that you kind of see is how when they do get hyperglycemia, how they respond to oral anti-hyperglycemic drugs. So type 1 diabetics don't tend to respond well to that, whereas type 2 do. So we're going to look at our diabetic medications, and we're going to start by looking at the anti-diabetic agents. And again, the focus here is going to be on type 2 diabetes. So all of these different types of anti-diabetic agents. So the key here is going to be looking at, number one, being able to recognize the names. Two, being able to recognize how they impact or how they bring down blood glucose, because that's essentially what all of these are looking to do, okay? So they're not insulin. And again, in some cases, type 2 diabetics will be prescribed insulin in addition to these potentially, but we're looking at specific drugs and how they work. Now, a very common first-line medication are your biguanides. Your metformin is a very common medication. It's generally well tolerated. So with all of these two, I'm also going to direct you to look at the common side effects. So there's common, like, mild side effects that you'll see with a lot of these. So for instance, with metformin, you know, very common to have like things like diarrhea, nausea, abdominal pain. They have a very low risk of causing hypoglycemia. So that's part of the reason why they tend to get utilized as a first-line treatment. So, and again, they're anti-hyperglycemic. So again, recognizing how they work, what organs they're basically going to kind of impact as far as, so all of these different anti-hyperglycemics will work in different ways. So metformin and the other biguanides that fall under here, again, metformin is also known as glucophage, they decrease glucose absorption and production. So one of the things they do is, as far as the glucose production, they're going to decrease glucose production at the liver, and they reduce absorption at the intestines. Okay, so that's basically the mechanism here as far as how they work. Okay, so decrease production of glucose at the liver, decrease absorption at the intestines. And again, all of these drugs are going to have different ways of doing this. That's going to be one of the things that you want to be able to recognize on top of any type of major side effects that they may have. So these are going to be contraindicated in individuals with liver or kidney dysfunction, which, you know, should make sense on the surface, because especially with the liver, given the fact they impact how the liver functions with glucose metabolism. And just another thing before we get into insulin secretagogues. So in individuals, there's no harm with these necessarily for use during pregnancy. However, they typically do prefer that individuals who experience gestational diabetes, they prefer to use insulin with them. So that's something to kind of look at as well when you're kind of doing this. And again, that's going to be at the discretion of the physician, but again, for patient education purposes, that's something that could always come up. Another thing that you do want to be aware of is drug-drug interactions. So individuals who are on meds to reduce their blood glucose, your textbook goes through different red flags. So one of the big drug-drug interactions you see with like something like Lantus is an interaction with ciprofloxacin, which we'll also be kind of talking about that with insulin and secretagogues as well, that there's issues with some drug-drug interactions there. So if someone's going to be, obviously, they're not necessarily going to look to change their diabetes medication in that circumstance. They may just want to look to go on a different antibiotic if something like that has to be taken care of. So insulin and insulin secretagogues, and again, these could sometimes cause hypoglycemia, but these are things that are very common in type 2 diabetes. So again, these particular types of medications, they're also known as sulfonylureas, and so we'll note some of the different types that gets talked about here. So the way these are going to work is they increase insulin secretion release by the pancreas. So these will directly work to get the pancreas to release more insulin, and these will also work at the liver as well. They're going to decrease blood glucose by the liver. So again, these are some of the important points that you kind of want to highlight for yourself. Again, potential things to be asked as far as like the learning outcomes in the test. Again, there's some different, again, note also the different types. So glucotrol or glipizide is one form of a sulfonylurea. that's going to be one that does get utilized here within this sort of drug category, if you will. They do not recommend utilizing these with when an individual is pregnant. And again, note some of the other like kind of common sort of lesser annoying side effects that comes along with this. And again, so note some of the drug interactions. Again, to highlight those red flags that kind of show up in the reading as you're kind of going through and make those connections there. There is an increased risk if you combine this with drugs like Jardiance, which we'll be talking about. Jardiance is another type of anti-diabetic agents, which we'll be talking about later on. And again, there's the contraindication here when combining with ciprofloxacin or your quinolone antibiotics. So some more anti-diabetic agents. So your sodium glucose cotransporter 2 inhibitors. So sodium glucose, so first you have to understand what sodium glucose cotransporter is. It's basically the predominant transporter responsible for reabsorbing glucose into the glomerular filtrate back into the circulation. So glomerular filtrate, that's in the kidneys. So we know we're kind of working at the kidneys here with this particular type of drug. So the idea of the inhibitor is to reduce the function of that and decrease renal glucose absorption. So instead of absorbing the glucose, we're looking to excrete it. So all this extra glucose, we're basically looking to excrete it in the urine. So we're basically preventing that reabsorption of the glucose back into the circulation. So under normal circumstances in an individual, this would be one area where glucose gets reabsorbed through that glomerular filtrate back into the circulation. Your popular version of this is Jardiance. That's going to be the primary one that gets prescribed for this. So again, there is a dehydration risk, so which should make sense if we're kind of impacting the kidneys and fluid absorption. There is a risk, and that gets compounded if someone is taking a hypertension medication. So if you recall, a lot of some of your hypertension medications work at the kidneys to bring down blood pressure. So that's kind of a highlight there. They don't recommend this for patients who, in individuals that have type 1 diabetes for the treatment of diabetic ketoacidosis. So, and again, you're not going to be responsible for knowing who should get prescribed what. Your job is to just know the medication, know the effects of it, know where it acts. And then we have what we call our GLP-1 or your glucagon-like peptide 1 receptor agonist. And these are going to, again, these basically create greater insulin secretion. So the idea here is that these are just going to enhance insulin secretion. So there's other things that they do as well. They enhance that glucose-dependent insulin secretion. They also slow gastric emptying, and they reduce what basically ends up reducing postprandial glucagon in food intake. So these basically get administered subcutaneously. They don't usually cause hypoglycemia in the absence of other medications that do that. So you're one of your GLP agonists, and these are very popular medications now. Your dulaglutide or Trulicity is one of the more popular ones that you see with this. And again, sometimes people do utilize these for weight loss, but you have to be careful with that because again, there could be potential side effects with that as well. So again, these if used with diet and exercise can be very good for glycemic control in individuals with type 2 diabetes. They actually recommend Trulicity as an adjunct therapy to metformin for patients who kind of have inadequate glycemic control with diet and exercise, so they do sometimes combine those. Again, they want to make sure that they only provide dulaglutide to patients who let, again, the benefits outweigh the risk when they're also at the same time taking metformin. All right, so now we move on to insulin. So we look at the use of insulin for managing both type 1 and type 2. Now keep in mind that for the most part, the more common application of this is with type 1 diabetics. However, sometimes in type 2, whether it's right away or eventually down the road, so a lot of type 2 diabetics eventually end up needing and requiring insulin therapy. So, and then they will take that, whether that's in combination with their anti-diabetic drugs, or again, sometimes the sort of the drugs that they get could change over time. That's also not unusual as well. But to be mindful of the fact that, so insulin will sometimes be required in type 2 diabetics, but normally we see this with type 1. So I would say in most of your athletic training settings, what you're going to see is particularly individuals with type 1 diabetes who are taking type 1, who are going to be taking insulin. Again, the idea is to mimic the pancreatic beta cell function. So that should all sound very familiar from our pathology talk. So the idea there is to basically mimic what happens under normal circumstances where insulin is going to get secreted in response to rising blood glucose levels. In the case of type 2 diabetics, there is the potential down the road or initially, depending upon the individual, to combine insulin with an anti-hyperglycemic drug. So when insulin is needed for patients with type 2 diabetes, usually glycemic control can usually be achieved with a combination of basal insulin and non-insulin hyperglycemic drugs. However, prandial insulin may be needed in some individuals, in other words, for when they're eating to kind of manage that blood glucose. Most insulin that you do have are what we call recombinant analogs. So they're recombinant human analogs, which this was kind of in response to individuals where there were a lot of allergic reactions to a lot of the animal sources. So if it basically, the manufacturer uses recombinant DNA technology to produce it, so it more replicates what humans will produce. So here's kind of the key with your insulin, and we have a little illustration that is exactly the same one that's in your book. So with insulins, you have to know how fast they start to lower blood glucose, and then what are the names of some of those insulins. So our rapid acting insulins, they reduce blood glucose within 15 minutes. However, they have a short duration of action, so they act really fast. They don't act very long. Humalog or insulin Lispro is your most common one of these. So these are best used at like meal times, obviously, because this will help control postprandial spikes in blood glucose. So these are, and some of these are actually available in inhalation routes. So that's one of the newer rapid acting ones. So inhaled insulin is a newer rapid acting type that can actually be taken with meals. Then you have your short acting, or what we would call regular insulin. So these are your human insulin R, Humulin R is the trade name. They have a slightly slower onset, so they take a little bit longer, so about 30 to 60 minutes to act, but they last longer. Okay, so unlike the rapid, which pretty much only have a duration less than 4 hours, these will go a little bit longer. This is the only insulin form that could be used in IV situations, although, again, obviously, individuals that use this on a daily basis don't use it in the form of IV. They use subcutaneous injection. The subcutaneous injection does lead to very rapid absorption in the circulation. Then there's the intermediate. So you get an onset of about 2 hours. It peaks at 4 to 12. It is a duration of 18 to 24 hours. So your intermediate acting insulins, Humulin N, Novolin N, also known as insulin isophane. So this is going to be your intermediate action. Again, this is like a concentrated regular insulin that has that same peak duration. Your long-acting insulins, so they're going to go out even further. Toujeo is one of the popular ones, insulin glargine. These insulins don't have a particular peak of action. These just basically provide a steady basal rate over 24 hours. So they don't have a peak of action. It's just a really super sort of slow releasing insulin over a long period of time. And then you have your what we call premix combinations. So sometimes we will kind of mix them, again, based upon, again, this could be something where, again, in certain circumstances where an individual may combine different types of insulin to kind of manage their blood glucose. So this is just a real simple chart that kind of complements what I just described. So going over, so you want to look at here is when it starts to work, when it peaks, and how long it basically acts for. And you could kind of see the difference. So again, if you wanted to, you could even maybe like, you know, in your notes, if you print them out, or, you know, you send in little text boxes to note the particular names that I mentioned and are mentioned in the textbooks with these particular types of insulin. So insulin dosing regimens and delivery devices. So again, again, we're looking to basically stimulate as closely as possible the insulin secretion by the body. So that's basically what we're looking to do. So the dosing is designed to kind of follow that. Basically, with each method, you maintain basal insulin levels, and ideally, you're looking to kind of look at this. And, you know, so for instance, boluses of like short or rapid acting insulin, they're going to be delivered before meals, okay? And again, the choice of this is going to be kind of done in collaboration with the physician. Again, you're not going to have a patient come to you, oh, I was diagnosed with diabetes, figure out what type of insulin I should take. That's going to kind of be decided, but another thing that might come into play down the road is, you know, as they become more active, as they, you know, get a little older, you know, there may be some things where maybe some things aren't controlled as well, and then that's where, you know, in talking with the physician, some of that could change. So the insulin pen, probably the most common thing you'll see. It's just a pre-filled insulin injection, and it gets injected into the subcutaneous fat. There's ideal areas of the body where this gets injected. So this is just an alternative to what was conventional. They used to do a vial and syringe method. So, you know, diabetics would carry around syringes in a vial. They would pull the insulin out. These are just pre-filled, a little bit more convenient. And you kind of see the areas of the body. There's an illustration in the book, and we'll kind of show where these areas commonly are where they'll inject them. And then there's an insulin pump where it's essentially a 24-hour infusion rate with the ability to adjust the rates. Okay, so this is a continuous subcutaneous infusion. Someone will literally wear a small, basically looks like a pager or a small TENS unit. It's basically worn for 24 hours, and it gives a constant gradual administration with the option that you could push a button. So say, you know, somebody eats something that is going to make their blood glucose go up a little bit more, which, you know, isn't suggested. Again, typically eat an appropriate diet as it relates to this, but sometimes people will, like, say, eat something, their blood sugar rises a little bit. It does give them the option to kind of like deliver a bolus, if you will, of insulin. So there's that option to do that. So, but again, the idea is to kind of keep insulin levels close to a normal, just sort of continuous stream as possible. So these are actually getting used much more commonly. There is a risk, obviously, of mechanical failure with this. That's one of the biggest things you deal with. But with active patients, it's becoming very popular in the physically active population because it just eliminates the need for all the different injections. It gives a little bit of flexibility with the timing with meals. You know, disadvantages, obviously the mechanical failures are a big thing. You could get pump failure, and that could lead to hyperglycemia. Sometimes the catheter can get clogged. There's also the potential for infection. So that can happen. sometimes, and usually what'll happen, so I've had one athlete that I could particularly remember personally. I had an athlete who had an insulin pump, and the funny thing is, again, I always say, two of the things you always look at with athlete control in our population is diabetes and asthma. So if you get someone that is a well-controlled asthmatic or diabetic, sometimes you almost forget that they have it. And at times with her, I would do that. And so she would take her pump off, but she was really good about managing her blood glucose, but she would remove her pump for games. And that's something you want to be mindful of as well, is that when individuals are exercising, and we're going to talk about this a little bit later on, that's where the importance in kind of managing the diet and insulin is really important. So you may have to change some of the requirements in insulin timing and administration as they remove the pump for exercise. So she would remove her pump, but that would obviously then impact how her insulin then would have to be delivered then after that. So it's just something important to keep in mind. And again, that should be something that you look at the beginning of the season when you're kind of looking at your medical histories. So again, illustrations from the book, you can see these. So you have your insulin pen on the side, much more convenient than using a syringe and vial to pull the insulin out. And then over there, you have the common injection sites for insulin. So the upper outer arms, the abdomen, buttocks, and the upper outer thighs are your common areas where insulin will typically be injected in individuals. So, and here's a picture of an insulin pump if you've never seen one. So again, it's just a little device. So again, the idea here is to keep the insulin levels as steady as possible in the case that, again, if they eat a meal that maybe has a little bit higher sort of like carbohydrate load, if you will, they may have to deliver a little bit of what we would call a bolus or a larger dose of insulin. Again, you obviously don't want to do that a lot, because obviously that's not good for overall blood sugar control, but if needed, they can do that. So you still have to do self-monitoring of blood glucose levels if you're doing this. Again, and that's important for all diabetics, type 1, type 2, regardless. Regularly kind of managing blood glucose is going to be something important for them to manage. So obviously, as it relates to kind of day-to-day in most athletic training settings, it's kind of this interaction with exercise and type 1 diabetes that we really have to kind of be mindful of, and having a plan in place. So you're going to have type 1 diabetics in your settings. Make sure to be aware of what their plans are, how they control their blood glucose, what types of insulin are they taking, do they have any problems? If they start to have problems, you need to manage it, okay? So again, prevents challenges. Again, hyperinsulinemia plus inadequate calories leads hypoglycemia. So hypoglycemia is typically going to be the problem you see with type 1 diabetics because of the fact they're taking insulin, and if the dietary glucose requirement isn't there, it's going to cause them to have hypoglycemia. So, and in the part where they describe exercise, so type 1 diabetics, again, they may have to reduce their insulin level by a bit. And again, that's going to be based on the intensity of the exercise. So you want to be sure to look at the intensity, duration of exercise. And again, these are probably going to be things discussed with the physician, but you have to be aware of that. If they're seemingly having problems, you may have to intervene and discuss with the physician and say, you possibly at least discuss potentially having another plan. Again, usually you're going to get consistent administration with an insulin pump. However, you want to make sure that if any adjustments need to take place afterwards, that gets managed appropriately so that there's not, too large of a swing in blood glucose levels. So in the diabetes care plan, so again, your role as an athletic trainer, one of the big things is, as you know, with individuals with diabetes, is being able to recognize hypo and hyperglycemia. So this is going to be an important thing to kind of manage, and we're going to go through specific points here. So again, blood glucose monitoring. Again, And any time that there should be pre-exercise exclusion values. So if you have your levels of high blood glucose, low blood glucose that are kind of at urgent levels, that's when exercise gets excluded. So that's an important thing to note. Again, your insulin guidelines. You should know what type of insulin your athletes and patients are on. Know the correct dosage, okay? Particularly and know correction dosages in cases that they have high blood glucose. So if an individual has high blood glucose, have an idea of the correction dosage if that's necessary. Again, list of other medications. And again, every time, so we had mentioned some of the drug-drug interactions. That's an important point to kind of be mindful of so that the other medications don't mess. And, there's other medications that could also cause issues with blood glucose, so be mindful of that. Signs and symptoms of hypoglycemia and know and recognize glucagon application. So this got discussed a little bit more at length, and we'll discuss again kind of some of the confusion that could sometimes take place with hypo and hyperglycemia. So, we kind of have the ideal signs and symptoms for both, but sometimes in real life, it's not quite that clear, and I'll kind of discuss some ways as we discuss some of the management of that as to how you could kind of easily differentiate. Again, knowing signs of ketosis, so there's particular things with ketosis that we talked about in pathology that kind of stands out. Again, sometimes the hypoglycemia can be a little finicky in practice, but we'll do how you can differentiate between the two. Emergency contact information. You should know who their physician is, what physician is managing their diabetes, so that in case you do have to discuss something. And all diabetic athletes should wear a medic alert tag. That's just kind of something even outside of the athletic setting that's important in the case that, say they're by themselves and they start to have a crisis, they can't communicate the right way. Someone could see, oh, they're a diabetic, and that could be, it can be a very important and life-saving thing. So managing hypoglycemia. So again, it's probably this is going to be the most severe acute complication. So again, this is going to be a very kind of rapid onset thing that occurs when you have somebody who's getting insulin therapy with diabetes. And exercise is going to be the most frequent cause. So we talk about hypoglycemia, the more severe hypoglycemia being less than 70. But mild hypoglycemia, when your blood glucose levels drops below 100, you're going to start to see symptoms once it drops below 100. As it drops below 70, that's when you have more severe reactions. And this is where things get to be a little bit more concerning. And, again, this is going to be secondary to a missed meal combined with increased activity and dehydration. So diet in the case of both type 1 and type 2 is a very important thing. So, and again, this is why we have some basic knowledge of nutrition so that we can, say if we do find that somebody is experiencing issues, we can kind of guide them on that. So, they shouldn't be skipping meals or snacks and we'll talk about, we talked about a little bit in pathology how we can kind of avoid this and ways we can do and manage this. So again, a lot of times type 1 diabetics will use trial and error. So many times, even in conjunction with the physician, they'll kind of think, okay, this is what they do. They'll trial it if they start to have problems. So this is why, for instance, I always notice working in a college setting, sometimes what worked in high school doesn't work in college for various reasons. And that's where maybe there would need to be a change. Usually when they're in high school, it kind of gets managed fairly well. They're living at home, they kind of have more of a routine. They go to college, that routine changes. So the other kind of challenge is that sometimes monitoring insulin, during activity can be very difficult, but it's something that you have to make sure. So hypoglycemia is usually going to happen if they take insulin or their insulin secretagogue, they skip a meal, they exercise for a long time or exercise strenuously, that's where you get this severe decrease in blood glucose. And again, in patients that are poorly controlled, they're going to want to take their blood. They're going to want to take their blood glucose prior to activity and determine if blood glucose is too high or too low. They may not even be able to perform activity that day. So it's important to kind of know those kind of like breaking points where for that day they may not even be able to do activity. Again, we try to hope to avoid that as we're kind of going through that. And you may have to potentially administer glucagon. Now, a glucagon injection is a pretty, when you're administering glucagon, and they may need this if their blood glucose is below 7. So this isn't like if it's below 100. This is if you're getting below 70 and you tend to have some other symptoms. So if they can't eat or drink anything because they're so confused or disorientated, which could happen, they may be unconscious. If they're unconscious because of having low blood glucose, they need glucagon, and or if they're having seizures. So in your textbook, they go through that whole administration and what's required and kind of what has to happen afterwards. So again, you want to also with this be, by the time someone needs a glucagon injection, you should be activating EMS along with that. They should wake up within the first 15 minutes of the injection, and then once they're awake and able to drink, you could then give them like sips of fruit juice or regular soda to kind of help restore glucose to prevent it from dropping again. But again, take a look at that sort of setup for that. There's also then the 15-15 rule for low blood sugar. So if their blood sugar isn't extremely low, but they're still classified as being hypoglycemic, you want to give them 15 grams of carbs. I don't remember. I'm pretty sure in the pathology chapter we talk about this, but you give them 15 grams of carbs, you wait 15 minutes. If they should get better fast within that 15 minutes, if they don't feel better within 15 minutes, you could give them a little bit more carbohydrate. This is also the trick. If you're unsure, because again, sometimes, know your ideal signs and symptoms for hypo, know your ideal signs and symptoms for hyperglycemia. Sometimes in the field, those things could get a little confusing, meaning that sometimes the patient could kind of look like they're presenting with a little bit of both. Now, usually hypoglycemia is very acute, so that's kind of obvious. If you're not sure, you can still do the 15-15 rule. If they're not getting better with the 15 grams of carbohydrates and they're having, some of these symptoms showing they could be hyperglycemic, then more than likely they're hyperglycemic. But giving them 15 grams of carbs isn't going to send them over the edge. At that point, it's not going to make a difference. But that's actually one way you could kind of do a differential if need be. So that's something to be mindful of as well. So again, see table 1313. It kind of goes through the differences between mild and severe hypoglycemia. Again, mild hypoglycemia, they're usually just going to have a headache. They might be sweating, a little dizzy, but they'll be conscious. They'll be able to swallow. They'll be able to talk to you. They just don't feel good. When they have severe hypoglycemia, so that's below 70, that's when they're going to maybe have very aggressive behavior. They're going to have seizures, possibly lose consciousness. That's when the symptoms get much more severe. Now, when we look at hyperglycemia, so your textbook talks about hyperglycemia, greater risk for type 1 than type 2. Individuals that have type 2 do experience hyperglycemia more by virtue of the fact that they just chronically have these elevated blood glucose levels. However, when you combine it with exercise, there's other greater risks associated with hyperglycemia. So, and going into that sort of ketotic state due to either missed or insufficient insulin. So, and in particular, you have to be worried about this in conjunction with whenever you're doing high intensity exercise. So the combination of a high blood glucose and high intensity exercise could really create a very urgent health situation. So high intensity anaerobic exercise is going to many times be the cause of the dramatic exercise induced hyperglycemia. and run the risk of like an exercise-induced ketoacidosis where so that's something that you do want to be kind of mindful of. So for athletes with diabetes, if they do high intensity exercise performed until failure, many times that leads to elevated blood glucose levels. And that could remain elevated for a prolonged period of time. So it is something that you do want to be mindful of. Again, you especially want to use caution as these levels increase. So again, hyperglycemia is going to be due to increased glucose levels that do not normalize as they do. So in non-diabetics, the blood glucose levels will go up as a result of exercise to help fuel it, but they're not going to be controlled. It's not going to be controlled in diabetics, obviously, the way it is in non-diabetics. And you, in particularly, want to use caution. So people with type 2 diabetes can engage in physical activity. However, they need to use caution once blood glucose levels are going to go above 300 milligrams per deciliter. So they can do that, but they have to make sure they're not showing symptoms of ketosis, and they have to make sure they're well and adequately hydrated. So that's what you want to kind of be mindful of with that. So again, people with type 2 diabetes, they engage in physical activity, they have to just use caution. Now, in people with type 1 diabetes, there's more risk there because their bodies aren't producing really any insulin, and that's where there's greater risk. So again, knowing the difference between how this kind of gets handled with type 1 versus type 2 diabetics are important. So in summary, again, we always talk about the management plan. So have a plan in place. You should be familiar with glucagon administration. So again, that whole procedure in the book you should be aware of. You should know what glucagon does. You should already know what glucagon does just as its natural function in the body. So again, there's position statements out there. They're always kind of a good thing to kind of review as a professional, because essentially when a position statement comes out, that's one of the things. If ever you're in a situation where, say, there's a legal issue, that's going to be kind of one of the gold standard things people look at is, do you follow the guidelines set forth by your profession? So it's really good. Anytime a position statement comes out, read it. It's telling you best practices and what needs to be followed. Again, be familiar with different types of medications, the different applications. So again, I'm not going to like make you decide what type of medication. You should obviously know a type 1 versus type 2 diabetic. Again, the anti-diabetic medications are for type 2 diabetes. Insulin is primarily for type 1, but they will use insulin in type 2 diabetics, usually in conjunction with that. So that you have to know, but again, you're not going to be given scenarios and have to make a decision. Are they doing a short acting or a long acting? You just need to be able to recognize how they work. And again, it should always be known that exercise is beneficial for both. So they should never be deterred from exercise. However, make sure you're aware of all the precautions. So the precautions that were discussed here and in the pathology chapter, you should be familiar with. And these are your learning objectives.